Welcome to the Cafe Culture podcast, a season of discussions on culture, politics, philosophy and science.
At a talk recorded on the 4th of July 2016, Roz Anderson discussed resistant bugs and failing drugs.
Okay, good evening everybody. So what am I going to talk to you about this evening? I really want to raise an issue which you must have seen in the news and in the papers, that we're beginning to see resistance to antibiotics. And this is a really big problem. And if nothing else, I'm hoping that tonight you go away with a sense of this isn't the doctor's responsibility or industry or people in other countries. It's our responsibility. It's for all of us to do something about. And so I hope that that comes across during this evening. So I'm going to assume no knowledge. I hope that's okay. I'm going to talk to you about bacteria, what they are, what they do, how they can cause disease, only a little bit of that. I'll talk about antibiotics because that's very relevant to the fact that we've got resistance. What antibiotics are and roughly how they work. I'll talk about resistant bacteria. What do we mean by resistant bacteria? And how did that come about? And is it still happening or has that stopped and we're just getting this tidal wave? And then I'll talk about why it's a problem and who it's a problem for. And then lastly, who's doing what about it and what can we do? So I thought we'd start off with a bit of a test. I haven't handed out exam papers, but I do come from a university, let's see. I thought we'd do a show of hands if that's okay. So how many people in this room have received antibiotics in the last 5 years? Quite a lot of us. What about in the last 1 year? What about in the last month? Okay, so, actually, I need to put my hand up again. So actually, it's very common that we take antibiotics. So that's the first thing. It affects all of us. And then I wanted to ask, were the antibiotics from a GP? Would you raise your hand if it comes from a GP? Or were the antibiotics from a hospital? Okay. So antibiotics can come from different sources, hospitals and GPs. They can come from pharmacists. If it's a prescribing pharmacist, they can come from dentists. There's a variety of sources. And that's quite important too. They come from different places. Can antibiotics cure all infections? Now then, how many people have seen that you shouldn't take antibiotics for a cold and flu? I'm hoping that everybody here has. Good, brilliant. Because antibiotics can't act on viruses, and viruses cause colds. Viruses cause flu, and measles, and mumps, and cold sores, and shingles. I could go on. So antibiotics have no use whatsoever against those things, and yet sometimes people go to a GP or they're given antibiotics for some reason when a bacterial infection is suspected, but it isn't. It's actually viral, and that's wasting the antibiotic. And another question, I'm not sure how to ask this without giving you the answer, but do we think that it's people that are resistant to the antibiotics, or is it the bacteria that are resistant to the antibiotics? Bacteria. Yeah. Oh, hey, this is a good class, this. I like this. Yeah, it's the bacteria. It's very common for people in general to think that they've become resistant to antibiotics, and that's not the case. You cannot be resistant to the antibiotic because it's not acting on you. It's acting on the bacteria, and it's bacteria that become resistant. Okay, so that's our test, and I'll throw the occasional questions at you just to make sure that you're awake during the process here. So, a little bit more introduction. Why am I talking about this? Well, it's something I'm really interested in to start with. as you know, I'm a professor at the University of Sunderland, and I have a number of roles there. And one of them is teaching pharmacy students. I get to inflict chemistry on them. And they all say, why have we got to do chemistry? But it's really important to understand about how the antibiotics work. So your pharmacist, if you need advice on how it's working or what it's doing or which antibiotic, ask your pharmacist. Plug for pharmacy. Okay. My favourite topic is about treating bacterial diseases and viral diseases, because I think it's so interesting. It's the science, so I've got my chemistry there, and it's the clinical aspects. How do you know which drug to use for which infection, which patient would have this, which patient would have that? And so it's a really interesting topic that pulls everything together, and I find that very good. But I also do research. In fact, I'm the lead for lab-based research at the University of Sunderland. And I've got several different projects. Two of them, to give you two examples. For one of them, I work on a rare disease called cystinosis. And that disease starts in children. It's a genetic disease. It's normally discovered sometime between 9 months and 1.5 years old. And if untreated, it's fatal before the age of 10. Unlike most rare diseases, they do have a treatment, but it's disgusting. So we've been working on a new treatment, and we're at the stage now of getting preclinical studies carried out in preparation for clinical studies. So that's one really exciting thing, where we've gone from design of a drug right through to a candidate which will go into clinical trials. And the other research that I do is designing and making new molecules, new chemicals, to help identify the bacteria that people have in hospital. When somebody goes into hospital and they get an infection, they'll take a swab, they'll send it to the lab. How do they know which bacteria it is? Well, we make chemicals that help the lab to work out which microbe is causing the problem. And that helps then with the clinical treatment. The clinicians know what to treat with. But I've got personal reasons to be really interested in this too. Because if it wasn't for some very good antibiotics that still work, I would not be here now. I would have died in December when I had some major surgery. Cut a long story short, I got peritonitis, which is a big infection in the abdomen. And it was so severe that the consultant told my husband to get our daughter home from university because I probably wouldn't make the weekend. I'm really delighted to say I proved them wrong. Without that drug that worked, I wouldn't be here. So for me, absolutely essential. And I think that all of us will know people who have been treated with antibiotics and probably wouldn't be here without them. So they are essential to us. Okay, why? Get on with it, Roz. Bacteria, what are they? Well, they're microorganisms. In other words, they're very tiny. We can only see them with a microscope. They evolved on Earth 4 billion years ago. And for 3 billion years following that, they were the only life forms on Earth. So they were here before us. That doesn't mean to say they own the Earth. But, there's many, many different types of bacteria. There's two sort of main classes to start with. There's the Cyanobacteria. Now, do I need to test you on this later, or do you think you'll have this? The Cyanobacteria, I'm not going to talk really about them tonight, other than they are the bacteria that provided the oxygen atmosphere so that life on Earth could evolve. There are still cyanobacteria growing. They still live with us, but I'm not going to talk about them. I'm going to talk about bacteria. That's the other group. There's cyanobacteria and bacteria. And I'm going to talk about bacteria. And you might think that you only find them in wounds or in illnesses, but actually bacteria are everywhere. If we put some special stain onto our hands and put it under a fluorescence microscope, you'd see bacteria on your hands. We have bacteria all over our skin, particularly in moist places like the underarms and noses. And mouth. You've got quite a lot of bacteria in your mouth. We've got millions of bacteria in our guts. In fact, there are more bacterial cells in our bodies than there are human cells. So there are very, very many bacteria. And you might think that that's a bad thing. But actually, if bacteria are where they're supposed to be, and in the right numbers, they're quite safe for us, for most people. So the bacteria on my skin cause me no problem whatsoever, so long as they stay on my skin. The bacteria in my gut, all of us have bacteria. For example, lactobacillus, and you might have heard of that because it's in some of those yogurty drink things. It's a natural gut bacterium that helps us digest. And some Bacteroides species are important, partly for causing immunity to other bacteria. They stimulate our immune system for us and try and hold back the other bacteria. And so those friendly bacteria are called commensal bacteria. There's another word for you, commensal. Commensal bacteria are the ones we're supposed to have, and they don't cause us any problems providing they stay where they're supposed to be. So that all sounds fine, really. What's the problem? Well, I can also divide bacteria down further into two groups. So these are just the bacteria now, not the cyano. We'll put those to one side. There are gram-positive bacteria and gram-negative bacteria, and they're given those names depending on their cell wall, the outer part. Each bacterium is one cell only, and it has a cell wall surrounding it like a little balloon bag, and gram-positive bacteria have a different cell wall to gram-negative bacteria, and that's the basis of that classification. So what I really want to get onto isn't the commensal bacteria, because they're fine so long as they're in the right place. It's the pathogenic bacteria, the ones that cause disease. So pathogenic bacteria cause disease. And there are very many pathogenic bacteria that are both gram-positive, and there's also gram-negative pathogenic bacteria. So both classes have lots of disease-causing ones. And you might have heard of some of these. Staphylococcus aureus, Staph aureus for short. Now that's the one that lives on our skin quite happily most of the time. But if it gets under the surface, it can cause impetigo. If it gets into your blood, it can cause toxic shock syndrome, which can be fatal. So in the right place, it's fine. Anywhere else, it isn't. If it gets in your GI tract, it can cause food poisoning. Strep pyogenes, we do have in our mouth, but if the levels build up and it gets into your throat, it can cause tonsillitis. In fact, it's the major cause of tonsillitis. Corny Bacterium diphtheria. What do you think that causes? Yeah. Some of them have good names, because then you know. Listeria monocytogenes. Anybody heard of that one? That's commonly found in unpasteurised dairy products, and that's the thing that causes mutations and damage to a fetus. So it's very dangerous in pregnancy to have unpasteurised dairy products. And it's that bacterium that's responsible for it. Bacillus anthracis. Any ideas what that causes? Anthrax, yeah. Fatal. Clostridium tetani. Tetanus. Fatal to about 10% of its victims. So really quite nasty. Clostridium botulinum. Botulism. Yeah, botulism. Deadly form of food poisoning. You get that and you're unlikely to survive. And C. diff. How many people have heard of C. diff? Because I think that's beginning to get heard about on the news. That's Clostridium difficile. And that's becoming more common in hospitals. It causes gastroenteritis. Okay, that's the gram-positives. Let's see how many gram-negatives you might know. Neisseria meningitidis. Okay. Easily fatal, easily and quickly fatal. Neisseria gonorrhoeae. The sexually transmitted infection, gonorrhea. E. coli, I think most people have heard of E. coli. Do you know E. coli, Shigella, Salmonella and Proteus all live in our gut anyway? It's just when you get an overdose of them, then they cause gastroenteritis. How about Yersinia pestis? That's one you might not have heard of. Sorry? Yes, it is. Well done, that lady. Extra mark. Didn't expect you'd heard of that. Vibrio cholerae. Cholera, yeah. found in... Now, this interested me because you'd think that bacteria could only exist in non-salty water. But that particular one likes salt and brackish water. You know, there's this fallacy that salt water's safe. It's not. And even if it doesn't have bacteria in it, it's likely to have little protozoa that also cause nasty infections. Cholera can kill within hours, and it only takes about between 10 and 100 cells of cholera to kill you. So it's very, very potent. Helicobacter pylori, you know what that causes? Yeah, stomach ulcers. Now, do you know that was only discovered about 30 years ago? I was a PhD student, and it's a guy in Australia that proposed that ulcers were caused by a bacterium, and everyone said, don't be stupid. So this guy drank a bottle of Helicobacter pylori and gave himself a stomach ulcer. And then he cured it with antibiotics. At that time, we had really good antibiotics that could cure it. And that was the only way he could prove it. And then the world believed him. Do you know, I think there must be better ways of getting people to believe you than that. I'm not going to try that one. How about haemophilia influenzae? Now this is a trick one. Causes pneumonia. And also, if it gets into your brain, meningitis. So it's a bit of a trick one, that one. Bordetella pertussis, whooping cough. And here's an old one for you. Brucella melitensis. Brucellosis, also called Malta fever, which killed our soldiers during the First World War and possibly the Second as well. Okay. So I'll move on. Hopefully you've got the idea that there are very, very many bacteria, and I've only picked a few just to try and get you thinking about the fact there's lots of them. Now, I've gone into some nasty ones there, but not all bacteria are bad. Remember that. The bacteria we have inside us live there, they help us. They're fine. It's only the ones that cause disease that are a problem. Okay. So, for years and years, all through my lifetime, and through, I would imagine, pretty much everybody's here, we've had antibiotics. And if you had an infection, you had tonsillitis or a nasty septic wound, you went to the doctor and you got antibiotics for it. Where did they come from? Does anybody know where antibiotics came from originally? Do you know who discovered the first one? Fleming. Back in... Hazard a date? Not bad. That's when the sulfonamides came out. 1928, Fleming discovered penicillin, wasn't it? Yeah. Antibiotics are molecules, chemicals, made by one bacterium to kill other bacteria. And that sounds a bit odd until you think about it. Well, of course, they're trying to get rid of the other bacteria so that they've got the food source to themselves. It's about survival. So antibiotics are natural molecules that we harness to kill other bacteria. But that doesn't include the general term. We also now have antibacterials, and those are man-designed, man-made molecules. We tend to just call them all antibiotics, though. We just put them all under the same banner. So that's what I'm going to do. So the aim of an antibiotic treatment is to halt the growth of the bacteria. And there's two ways of doing that. You can either kill the bacteria straight off, that's called bactericidal, or you can just stop them growing, and that's called bacteriostatic, because you keep them in stasis. And you might think that's not going to be very helpful, but actually, if you can stop them from growing any more, then your own immune system can take over and kill the bacteria for you. So really, some antibiotics are just there to help you then kill the bacteria yourself. It's important, though, that they only kill bacterial cells. So antibiotics have to be selective. They mustn't damage human cells. Otherwise, they're going to harm us. And so there has to be selectivity. Now, penicillin, as we know now, was discovered in 1928, but it didn't come into clinical use until the 1940s because it's a difficult chemical structure to make. In fact, we still use bacteria to make it for us. And back in the 1940s, it needed to be introduced quickly for people who were dying during the war and from TB. And two chaps called Florey and Chain down in, I think it's Cambridge, but it might be Oxford, one of the big cities. They were growing the bacteria that make penicillin in bedpans and then collecting the penicillin and giving it to patients. But the bacteria couldn't grow the penicillin fast enough. So a lot of the penicillin you take comes out unchanged in the urine. You know what I'm going to say, don't you? They collected the urine from all the patients and got the penicillin back out and then gave it to more patients. And that's what they had to do back at that time. The sulfonamides were actually the first ones on the market, used clinically, because they're easier to make. Has anybody heard of sulfonamides before? Do you know where they came from? Put you on the spot. They actually came from dyes, from the dye industry. And it was ICI that were making sulfonamide, azo dyes. And it was found that bacteria could reduce those azo dyes, and it made sulfonamides which killed different bacteria, not the ones that reduced them, but other bacteria. And that's how they were discovered. And in fact, without sulfonamides, World War II might have been a bit different, because the sulfonamides were used very, very early to save Winston Churchill's life. When he came back from Africa, he had pneumonia, and without that, he wouldn't have survived. So in the late 1930s, early 1940s, sulfonamides started to be introduced. TB was a big thing at that time, and anybody with TB had a slow life sentence, or death sentence really, because it took a long time to kill them, but there was no cure for TB. And the sulfonamides were a sentence removed. They allowed people to live who had TB. So it was a really huge thing when they came in. Since then, there's been many, many other classes either discovered, so they're antibiotics, or designed and made antibacterials. In the 1950s and 1960s, up till 1975, and trimethoprim was made in 1975, and then nothing until 2005. So we have a time from 75 to 2005 when there were no new classes of antibiotics. 2005 was when linezolid came out. Now, the reason I'm giving you all that background, you would think that having discovered them and started using them in 1940s, antibiotics became clinically available. Surely it must have taken till the 70s or 80s before we saw resistance develop. And actually, do you know that's not the case? The first case of resistance to antibiotics was to penicillin before it had even been used clinically. In trials, it was found, some bacteria were found to be resistant, and Fleming himself said, this is a problem for the future. We need to be careful of this. But unfortunately, nobody took note. So antibiotics act by killing the bacteria or stopping them growing. They target, we need selectivity, remember, so they target processes that are specific to bacteria that we don't have. So, for example, synthesis of vitamins that bacteria can make and we don't, we have to take in our diet. Or the bacterial cell wall. Humans don't have a cell wall. We've got plasma membrane around our cells, which is a different little bag around our cells. So bacteria have a different cell wall. And so they target those. The choice of antibiotic used depends on lots of things. You'd think you could just throw anything at it, but you can't. Because some antibiotics only act on gram-negative bacteria. Remember I said there's gram-negative and gram-positive? And other antibiotics only act on gram-positive. Broad-spectrum antibiotics act on the majority of bacteria. But even then, there are some bacteria that have natural resistance. And TB is one which is very, very difficult to treat. It's got a very waxy outer cell, and it's very difficult to get drugs in there. So a clinician, when they're giving antibiotics, needs to know what the infecting species is, so it knows which antibacterial to give, which antibiotic. Is it a lethal infection? Is it going to kill the patient? Is it going to kill them? Or can they get better naturally? And what are the local bacteria? What do the local bacteria respond to? So how did resistant bacteria arise? Well, antibiotics have been around as long as bacteria have. Remember, bacteria make them to have their food for themselves. And so antibiotics have been here a long time. And it happens because when cells divide, the DNA has to be copied for the new cells. This happens in us too. And if there are mistakes made, those mistakes can be propagated. Now, we all make mistakes. We do too. When our cells multiply, they make new DNA and mistakes are made. But we have a checking mechanism that takes most of those out. Despite that, there's between 100 and 200 mutations every generation in our own DNA. Bacteria divide very, very much faster, and there are very more mutations. And so they develop new proteins, new ways of destroying these antibiotics much quicker than we can respond to drugs. So the bacteria develop methods for becoming resistant. They make enzymes that break down the antibiotics. They change the target a little bit so the antibiotic doesn't attack it. They're quite sneaky, really. And they also change the way the antibiotic gets in. So they either change the pores that the antibiotic can get in through, they're called porins, or they change the efflux. And efflux are these pumps that most bacteria have that can pump out unwanted substances. If they increase the amount of these pumps, they can get rid of the antibiotic, so the antibiotic never gets to the amount that it needs to get to in order to kill the bacteria. So they've got all these little mechanisms for getting round our antibiotics. Now the impact of that resistance is that we then have bacteria that we can't treat. Can anybody give me an example of a bacterium that they've heard of that we can't treat?
MRSA.
Perfect. MRSA, up to 20% of MRSA infections are fatal because we can't treat them. And 86% of those are caught in hospital. It's a dangerous place to go, actually, hospital. VRE, Vancomycin-Resistant Enterococci. Now, enterococci are the bacteria in your gut. And they're fine so long as they stay there and there's not too many of them. But if you eat food that's contaminated with somebody else's bacteria from their gut, because they haven't washed their hands, then you might get gastroenteritis. And some of those now are resistant to vancomycin. Was one of our last resort, very, very potent antibiotics. And some of those enterococci are now totally resistant. Up to 25% fatality rate for people with a vancomycin-resistant infection. TB. There is now multi-drug resistant TB, not just in hot countries, but it's coming back to the UK again. And I guess that's partly because of travel and because we now don't vaccinate our children again. My daughter's year was the first year that did not get the TB vaccination, so they're not vaccinated. 1 in 5 people die from multi-drug resistant TB. And actually, TB is becoming a real problem in the UK again. Do you know it kills more patients worldwide than HIV does, than AIDS does? TB is more of a problem than HIV. And we're also seeing other examples. We're seeing examples of bacteria that aren't just resistant to one class of drugs, but are resistant to all drugs. That's called pan-drug resistance, PDR rather than MDR. And part of that, is because bacteria, they don't just pass it down to the daughter cells. So if a bacterium mutates a protein and then it manages to destroy the antibiotic that's supposed to kill it, it's going to keep that protein. It's going to hand it on to all the cells that it makes. That's called vertical transmission because it goes from parent to daughter cell. But they're a bit sneaky because they also do horizontal transmission. They make little round circles of DNA that carry the information for these resistance genes. They're called plasmids, these little round bits of DNA, and they give them to each other. Now, at first, they only gave them to bacteria from the same species, but now they can give them to other bacteria. So, an Acinetobacter bacterium can give it to Pseudomonas and E. coli. That didn't used to happen. It's happening now. Do you know, in the US, I was watching a video of a consultant explaining the first time he met a patient with an infection that he couldn't cure. And it was an Acinetobacter, which is a gut bacterium. And this lady of 26 years old, they threw every single antibiotic at her. And they got 4 weeks where she started to get better, and then she got ill again. And then they tried another one, she got better, got ill again. Do you know that lady died? She had 3 children, and she died at the age of 26 due to a bacterial infection. 10 years ago, that would not have happened. That consultant broke down when he was explaining about it. That is becoming more common, and it will affect all of us. That was in America. We know it's happened in Germany. We know these cases are moving closer to home. Some of this arose, I did say I'd speak about Asia quickly. This is not an Asian problem. I want to get that across to you first. It does happen that in some Asian countries, their healthcare systems are not set up in the same way. And so the scrubbing, as I would call it, the cleaning of bacteria from waste is not carried out before the effluent goes outside the hospital. And it's very common to find, for example, bacteria that are totally resistant to all drugs that would cause a urinary tract infection in hospital, in the areas around hospitals, communities outside hospitals. It's not uncommon. But then those are carried overseas. They come to us. So that's why we're starting to see these things. We've got antibiotic-resistant gonorrhea, which started in Leeds, not Asia, Leeds. And it's all over the place now. It's very, very common in Manchester, Leeds, London, Birmingham. It's untreatable. So what's happening? What's going on? Well, you might have heard of the O'Neill reports. Has anybody heard that on the TV? Lord O'Neill was asked to lead a group to review the problem. And they've looked at the problem now, but also predictions for the future. So he's now got 3 reports out. I'm not going to go into them. But some of his predictions really make you think. By the year 2050, so it's only just over 30 years, and hopefully most of us will still be around at that time, there will be more than 10 million extra deaths globally due to resistant bacteria. Not just every disease, but resistant bacteria. Deaths that we don't have now, but those will be extra, more than 10 million extra per year.
Is that worldwide?
Yes. Since summer 2014 until now, he says more than 1 million people have died from bacterial infections resistant to antibiotics. It's so unnecessary. We wouldn't have had that previously. But this is the situation that's arising. And it's not just people it affects, it's the economy. The cost of those 10 million deaths and all the illness that goes with it, the economic cost is greater than £69 trillion per year in lost output. That's greater than the current world economy, and it approximates to losing 35 years of the UK economy. So this is a huge economic cost. I'll try and be quick. I'm going to get dragged off, aren't I? You know, one of those little sticks. I'm glad you haven't got a shepherd's crook. So what's happening? What are the professionals doing? Well, GPs have what's called Target, an antibiotic toolkit, and they have to update their education on antibiotics. Doctors are encouraged not to prescribe antibiotics unless it's life-threatening or severe. And that's something that we need to think about. Should I really be asking for antibiotics for this, or am I fit enough to overcome this myself? In hospitals, they've got Start, Smart, Then Focus, antimicrobial stewardship guidelines, which is about getting the right drug at the right dose, at the right time, to the right patient, every time, getting it right every time. Now you're going to ask, are any new antibiotics being developed then, if we've had this big gap? Well, the trouble is, the economic climate is not good, because for pharmaceutical companies, you give an antibiotic for a week, the patient gets better. They don't make any profit out of it. Why would they put in the millions and millions of pounds it costs, over 1 billion to develop a drug to market? Why are they going to put that in when they're not going to get the money back? However, government has said that they have to. And the new, very new report that came out last month says that pharma industry will either have to develop antibiotics or pay a penalty, which will be used to fund more research into antibiotics. We must move forward on this. Some industries have already started. So Novartis and GSK, for example, are already developing new drugs. Okay, so that's everybody else. It's not everybody else's problem. It's our problem. What can we do about it? We have to recognise this is not Asia. This is us. It's here, and it's developing more and more. We've got drug-resistant gonorrhea. Remember, the bacteria can pass on that resistance. We need to educate friends and family. Try and make sure that they know not to ask for antibiotics if they don't need them. Don't seek them. It is important, though, that your healthcare professional, your GP, your pharmacist gives you the advice. We can't make those decisions for our children or for people who are immunocompromised or elderly. Think of meningitis, for example. In a child, that can develop within 24 hours to fatality. So we can't say, oh, they've just got a cold, I'll not go. If it's somebody vulnerable, we must let the professionals make those decisions. When you have antibiotics, always complete the whole course. If you stop it because you feel better halfway through, then the bugs that haven't yet died or been killed by your immune system have some antibiotic there, not enough to kill them, but enough that they can develop some immunity to them, and then they pass that on. So we must always take the full course. Never give them to anybody else for the same reason. You're not finishing your course, and they're not getting a full course, and they probably don't need them anyway. We need to not put pressure on our GPs to give us antibiotics. Let them decide. They will know. So what do I want to... I'm sorry if I'm just rushing the last bit, but I'm hoping that I'm getting the... Yeah. Last bit. Please remember, antibiotics only act on bacteria and fungi, not viruses. And if you take antibiotics when you don't need them, all it does is kill your gut bacteria and allow other nasty ones to flourish. So you're harming yourself as well as risking resistance. I'm sorry I went on a little bit longer, but I have finished at last.
Caviculture North East is supported by Newcastle University, Peels and Dance City. We're also supported by DC Cafe, who host the events.